chat. Now let me begin by introducing you to tonight's presenter, Dr. McCarthy. Dr. McCarthy is a board-certified urologist and chief of surgery at Columbus Regional Healthcare System, where he leads advanced urology with offices in Leland, Whitesville, and Magnolia, North Carolina. Dr. McCarthy earned a master's degree in kidney physiology from the University of Georgia before completing his Doctor of Osteopathic Medicine at the Pikeville College School of Osteopathic Medicine in Kentucky. He then completed his urology surgery residency at the Detroit Medical Center at Michigan State University. With more than 2 decades of clinical and surgical experience, Dr. McCarthy has built one of the most active urologic surgery programs in southeastern North Carolina. He is an SRC-accredited master surgeon in robotic surgery and, as chief of surgery, led Columbus Regional to accreditation as the region's first center of excellence in robotic surgery. His clinical expertise spans the full spectrum of urologic care, including prostate, bladder, and kidney cancer, BPH, kidney stones, and urinary incontinence. Dr. McCarthy is committed to bringing the latest minimally invasive technologies to patients close to home, and under his leadership, Columbus Regional became the first program in southeastern North Carolina to offer Focal One robotic HIFU for the treatment of localized prostate cancer. So without further ado, I'd like to welcome Dr. McCarthy. Thank you for being with us tonight and for your time. The floor is yours.
Sure. Thank you for having me. Can you hear me?
Yes, we can hear you.
All right. Yeah, after hearing that, I'm kind of impressed, whoever that guy is, but thank you for the introduction. I've been about 20 years in the area treating urological cancer patients, prostate cancer by far being the most common one that we see. So kind of just go over the agenda a little bit. I'm going to talk a little bit outside these slides as well. And anybody who knows me, I could do kind of different derivations, really trying to home in on getting people to understand why their situation or their disease process is different than somebody else's. I always use different analogies that really help people understand, kind of what they're dealing with and why my conversation is drastically different for the next person who walks in the office. All right, for the agenda today, we'll talk about, what is PSA? What is it? What does it mean? What are the potential reasons why prostate cancer? What are the treatment options for that? What is HIFU? What are the potential advantages? What patients may be suitable for it? If I decide that I'm a candidate and want to undergo that therapy, what would the treatments be like? What happens before, during, and after? And then what are the outcomes that other people who've had that treatment? And at the end, we'll have a chance for anybody to answer some questions. Number one, prostate cancer is by far the most common cancer that we see in men in the United States. I always hear what I would say is information that a lot of people think is accurate and very, very commonly said to me, but not necessarily true. Everyone gets prostate cancer when they get older, and no, that's not the case. 288,000 cases a year, we would see the numbers somewhere in the order of about 10 million. So only about 1 in 6 or 1 in 8, depending on, which, study that you read, actually gets it. So if I told you there was 1 in 6 chance of getting prostate cancer, and that's 18% of the population, and I could flip it and say, well, actually, most don't get prostate cancer, 82% don't get prostate cancer. And then the next statement I commonly hear is, well, no one really dies from prostate cancer. And if we look here, 34,000 men die from prostate cancer every year, right? So when you look behind lung cancer, number 2 cause of cancer death in men in the United States is prostate cancer. You never hear anyone say, well, no one really dies from colon cancer. No, of course, right? We know that that could be a serious cancer. More men actually pass away or lose this battle from prostate cancer. But then we look at that blue, and what we see is there's a lot more people diagnosed. So then we need to understand, well, what type of prostate cancer is it? Ultimately, when we know that someone has skin cancer, the first question people want to know is, well, what kind? Is it a basal cell cancer where there's a little spot that someone has to just do a little surgery for and it's easily curable, and that's probably all we'll get? Or is it melanoma, and melanomas can be very deadly, right? But prostate cancer just has one term, and it's a very, what I call, heterogeneous disease, meaning there are all these different types of aggressiveness. And then we need to understand which one it is so that we can best characterize whether or not it is one that we can watch, whether it is one that we need to treat, or ultimately one that we really need to treat very aggressively. Million men a year get prostate biopsies. There's about 3 million men that are living with prostate cancer. So the idea is if we ever get something, understand it early and cure people, they can live with it. Treatment stops and they move on with their life. What is PSA? I hear all this, oh, well, there's a lot of things that cause the PSA, and you go online and you can read, yeah, you're riding a bicycle, my prostate could be big. Yeah, there's a lot of different causes, right? So it's just a blood test. It's an enzyme produced in the prostate. Well, what's the purpose of the prostate? The purpose of the prostate is for fertility. After that, as we age, and some men it gets enlarged, some men it can develop cancer. But this PSA is just a blood test. What I always tell people is just gather the information. If it's normal, then you got no concern or a low risk for prostate cancer. If it's elevated, then get to the experts that can do a good job of discerning, well, what does this specifically mean in me? What I always tell people is like 20 years ago, all you had was a finger exam, and then you had a PSA, and I'd say, you want a biopsy? Right? Now we have so many different ways to make sure that we start pulling people apart on the ones that are really at higher risk for what we call clinically significant prostate cancer, right? So the PSA is the initial test. I'm not asking someone to run a marathon. Just get it with your normal blood work with your primary care doctor. And then if it's elevated, get to someone that you sit across from you and explain to you what are the potential reasons why, and then let me find out the reasons why. And I always tell people that is at this point, I don't always know why it's elevated. I absolutely will find out what it needs. Okay. And the inflammation, right? Simplistically, my prostate could have got a little bit irritated. I could have a really big prostate. My flow could be weak. I'm always asking different questions about, all right, how are you emptying your bladder? All this knowledge that I'm trying to get to say, maybe I think someone's just got enlargement of the prostate, right? And then we have other tests. I can get urine tests and blood tests that'll risk stratify patients to say, what's the chance they're having or at risk for a significant cancer? I love the prostate MRI. So ultimately, I will get one of these urine tests or blood tests that look at DNA or proteins in the blood or the urine that'll help tell me high risk or low risk for significant cancer. And I keep using that term significant cancer. If I find an indolent one and all the data says it's that, I will watch those, trying to pull the people out of the lineup that have ones that have a significant chance of harming them in their lifetime. MRI not only can find 80 to 85% of clinically significant cancers, but it then 3D maps your prostate and tells where it's located. Before the days of the MRI, when I only had the finger exam and the PSA, we would miss about 30% of clinically significant prostate cancer because they were in different zones. Now the MRI will tell us exactly where it's located, and I have these fancy computers that 3D map the prostate, and then I do the biopsy, and the computer actually tells me where it is, so it takes any guessing out of it. And I always tell people, I don't want you to have prostate cancer, but if you have it, I want to find it and have the best chance of accurately characterizing it so then we can make the best decisions on what to do and what not to do about it. And then the dreaded prostate biopsy. And the prostate biopsy for me is I've got a couple pieces of data that say I'm at higher risk for clinically significant prostate cancer. And then where and how I do the biopsy is dependent on where the spot is or spots. If there's a very low lesion right near the rectum, it's very easy to do a transrectal biopsy in the office. If it's a high lesion that's already all the way on the other side of the prostate, it's very hard to get a needle to reach all the way across to there. I could bring someone to the hospital and do a transperineal MR fusion biopsy. So it makes it much more accurate because I'm able to just go straight to the tissue instead of trying to come all the way across to get it. After that's done, we do some other testing as well. The pathologist, if he tells me there's prostate cancer, gives a Gleason score. Then we could do genomic testing. Genomic testing, there's a lot of different forms of it. There's one that uses the pathology slides and artificial intelligence, and it's really kind of a backup. As yeah, the pathologist told us this how aggressive the cancer is, kind of a verification system. Some of the ones that I like to use actually take the highest core or most aggressive core, if there's several that are positive, and looks at the DNA. And inside there, it's looking at different factors and mutations that'll also ultimately tell us how aggressive or how fast it looks like the cancer is going to grow. So that I have more data points to say, all right, well, one of these doesn't necessarily tell me the story, but the other 4 to 5 data points say this is really what we need to think about. And these are the treatment paradigms that we need to think about. All right, prostate cancer treatment options. Back in the day, actually, I'm 50, so I'm just, old enough to where I loved as a resident doing surgery because you were just learning how to be a surgeon, and there were all these open radical prostatectomies, but it was very hard to see down in the pelvis. Your hands were in the way more than they were helpful, but that was the only way to get it out because that's what your tool was. And then when I was training up in Michigan, really across the street, the robot was kind of starting at Henry Ford, and being next to your neighbor that had it, I was kind of put into it early on, and that became kind of what I was, hired for down in southeastern North Carolina. And over the years of doing the first 1,000 cases, 2,000 cases, up to 3,000 cases now of a robotic procedure, we have definitely improved techniques. But now we're also starting to see, since we have better characterizations with MRIs and we find cancers that are earlier, maybe we don't have to treat the entire gland. Maybe we can just treat the tumor and potentially have less collateral effect from the treatments. Because the biggest thing people don't want is, well, I don't want to die from the disease, but I don't want the treatment to be just as bad as the disease process itself. So when we look at the paradigm of prostate cancer, I tell people we've got the basal cells all the way up to the melanomas, the slow growing cancers all the way up to the very rapid ones. The low risk ones, which we identify a lot of people as Gleason 6. Now, sometimes the biopsy says Gleason 6, but I've got other data that says it's more aggressive than that. Sometimes the biopsies can just disagree a little bit with what all the other data is. So I use all of those to make sure I really feel like someone has a Gleason 6 and should be placed on active surveillance. Every now and then when I see someone that are on their active surveillance, they see me for a second opinion and their PSA is 30. Your PSA is not going to get to 30 with cancer if you have a Gleason 6. So I want all those data points to make sense to me to make sure that I can watch somebody. And then we start heading to the intermediate risk. And these are the Gleason 7s, the 3+4s and the 4+3s. And then the higher risk patients, the patients that really need a more aggressive therapy, Gleason 8, 9s, and 10s. And then there's some level of salvage treatments. I always say it's every treatment that we do has some form of a backup if it's localized. So if we have surgery, we could do radiation afterwards. If we have radiation that fails, then sometimes we can consider some type of ablative procedures, even including HIFU. All right, let's keep going here. All right, so treatment options, right? This is the dreaded things when people, and I had 2 guys today before they're even, told that they had prostate cancer and they just told they needed a biopsy. They say, you're not taking my prostate. And I said, well, you've already diagnosed yourself with a significant cancer and you're already talking about treatments. I don't know even if you have prostate cancer. The same idea here is they're worried about number 1, incontinence, and then number 2, ED, right? So I always tell people what doesn't get easier as we get older is our ability to maintain or continue to have erections. So any treatment has the potential to have a bigger effect on that in a population that already is potentially having more issues with that, just because as we get older, it gets a little more difficult. But active surveillance, right? So this is watching those low-grade cancers. Yeah, it's always amazing to me, right? There's a certain percentage of men that are just going to have problems with erections. 2 to 6% of the normal population has a little bit of incontinence. Focal HIFU, right? So the procedure that we're going to kind of talk a little bit more about. Incontinence is kind of the same rate as the general population. The same idea with the erections. The reason we're talking about focal treatments instead of having just big collateral effect, maybe we can just have a localized treatment and leave the rest of it alone. Very little bowel dysfunction. Every now and then, if the tumor is close to the urethra, you got to be careful with that. About 3 to 5% of people can develop a stricture. And when you look at surgery and radiation, yeah, absolutely, surgery has the highest chance of incontinence. I think those rates have improved with robotic surgery and the high volume guys. ED, right? Everyone's variation. I mean, typically these guys might be a more aggressive cancer too, so maybe you can't save the nerves. But in general, yeah, uh, bladder function and erections are an important component of their decision making. And sometimes you really have to kind of put into perspective why you're thinking about certain things to make sure that you're still treating the cancer adequately in this population. What is HIFU? What is high intensity frequency ultrasound? Very simply, it's a minimally invasive, non-surgery. There's no cut and there's no radiation. Basically, when you look at this, there's a probe while the patient's asleep that goes into the rectum and then ultimately measures and looks at the gland using all these fancy computers and technology. And you can even align the MRI with it. And then uses this ultrasound to go in and basically zap precisely the areas that you want. Typically, we will do partial gland or we will do tumors. I usually don't do whole gland. So ultimately, I want to do select patients that don't have or need treatment on both sides of the prostate. When you look at the type of platforms that are available out there for HIFU, I do think the reason I chose this platform is this is a generation ahead of all the other ones that were available out there for years. And every now and then, just similar to when all of a sudden we saw the first TV that became flat in the back and we were amazed, the same idea with the technology that we use on this machine compared to the other ones, to me, really sets it apart. It's robotic. The technology inside the computers allows me to see precise images. It allows us to align things much more consistently, and the movements are much more precise so that I can really home in at exactly where I want to treat and minimize the treatment around it. Some of the advantages: no incision, right? So there's absolutely no type of recovery from an incision, staple, stitches, or anything like that. It's outpatient. I do it, you go home later that day. You will wear a catheter for a couple of days because you're going to see a little bit of edema swelling inside the prostate. But people don't like spending the night in the hospital. You don't have to here. Pretty soon after the catheter comes out, I let people say it's 24 hours. You feel good. Everything is fine. You go back to your normal activity. Especially a lot of the patients around here who are retired and now very active and they want to get to golfing or doing their activities they enjoy. And minimal side effects. We want to decrease the amount of incontinence, number one, because that's a severe quality of life change. And then two, the erection component. Who's suitable for this type of treatment? As I said before, if someone really is diagnosed with a 3 + 3 = 6, they got it in a high volume on one side. I see something on the MRI. I'm not convinced it's a 6, even though the biopsy says it, and maybe the genomic testing suggests it could be a little more aggressive. I'll treat those. My favorite patients, typically 3 + 4s. And then I will do guys with 4 + 3 as long as it's within a certain realm where the tumor's not too big. It's not all 6 cores, maybe it's 1 or 2 cores, or my guys that are a little bit older. So I really try to home in on specifically making sure that if I'm going to do something like this, that we really have the best chance of success, which is eradicating the tumor and lowering the PSA, and so it doesn't get outside the prostate. So, some patients aren't suitable for prostatectomies either, right? Multiple bowel incisions, so you look at their abdomen and they've had so many surgeries, there's no way you want to do surgery on them. Obesity, location of the tumor size of the prostate, certain other disorders, adhesions, previous radiation, things like that. All right. Treatment day. So patient comes the morning of the treatment. They'll do a bowel prep the night before, just try to get stool out of the way so the ultrasound can really show a better image on the prostate itself. This has to be general anesthesia. Why? Because it's a robotic platform. So once we align the prostate to the ultrasound, everything has to be. And if a patient moves just a little bit, the robot lets me know when it stops the treatment immediately. And I got to make sure the patient's asleep and everything's aligned again. So it's very, very precise. But you definitely have to have general anesthesia. And the good news is you don't feel anything. So we do the procedure with the focal one. We try to get as precise as we can, a blade in it. The procedure length depends on how big the prostate is and how much of the gland that we're treating. Anywhere between 45 minutes and 2 hours is probably somewhere in that paradigm. And then catheter goes in right before the procedure. They go home with the catheter later that day. So at the end of the procedure, we put the catheter in. They recommend it 5 to 7 days. In general, that's the recommendation. And if someone can't pee 5 to 7 days after the procedure, then we give them a couple more chances. We might put them on a medication like Flomax that will help them, empty easier. Typical follow-up is with PSAs, either 3 months or 6 months, and then 1 year. And then at some point, we're going to repeat the MRI. I always wait to see what I see the PSA doing and get a good sense of I like what I'm seeing, and then I'll get the MRI somewhere between 1 year and 2 years. And I really wait until I have enough time where the treatment effect can show what I want and the PSA is still proving it. If the PSA is not doing what I like, I'll get the MRI sooner than that. But ultimately, I give it enough time if the PSA is really telling me the story so that we can hopefully see that that lesion completely is gone at some point. And the reality is the follow-up can be with anybody. We have people travel around for the robotic procedures and these procedures. And sometimes it's 2, 3, 4, 5 hours away. We've treated people from several states, all the way from New York and Maine to Florida the other day to Georgia. So you come for the treatment, we get hopefully the results we want. You go back to your primary urologist and they continue to follow the PSA. What is some of the clinical data? So there's a lot of different studies out there that kind of show that this has been tried and true. When you look at like HIFU, and we can compare it against radical prostatectomy, but HIFU has been out there for a long time, first in Europe. Then when I came to the United States, before it got approval here, people went to Canada or down in the Caribbean to get it done. But anyways, 3,300 patients were treated at 46 different centers, and it was comparable in most patients to a radical prostatectomy, but significantly better urinary incontinence rates, which are important, and then less ED issues. Right. Number one, I always tell people it's cancer, continence, and erections with all of this. If you don't get the good cancer control, everything else is hard to even worry about. Once you get past there, then you got to get dry if you have a prostatectomy. Well, if you never leak, you're on to the next thing, working on the erection component of it. I always tell people all three of those things are important to me, and we're going to work on them all at the same time. But you got to get past the cancer perspective first to even worry about the next steps of everything. Okay. So a lot of different tests out there that, studies that have shown that, the one thing I think we see this for as well is salvage radiation therapy patients. So I think there's a really big study that just came out, and it basically said that salvage rates for radiation failures are good. I really don't like that they're taking the prostates out because the tissue just doesn't heal. this can go in, hopefully ablate the tumor if the localized area of reoccurrence is just inside the prostate itself. And then it can avoid, hopefully, the spread to outside of the prostate. Simplistically, no scars, no blood loss, no radiation, in and out procedure. I think it really fills the gap where, this isn't an active surveillance patient. This isn't a patient that I just want to watch or meets the criteria to watch. This isn't the super aggressive ones where we need to throw the whole kitchen sink at them. There's some a good middle ground. And what I tell people, I like it, right? So we have everything that we can offer patients: active surveillance, surgery, radiation, or ablative procedures like Focal One. The data's really getting better. I think the technology continues to improve, as well as the coverage for insurance. Early on, the coverage was harder, but now that there's just a huge paper that came out again that said it's one of the best treatments for salvage radiation therapy, you're going to see even more commercial and Medicare reimbursement. And the new generations continue to get more precise so that the procedure times can be cut down as well. All right, that's it.
All right. Thank you so much, Dr. McCarthy. We did have some questions that came in. For starters, one came in, I think you might have touched on it, but I'd love if you can kind of talk to it again. Can you get HIFU if you've gotten radiation done?
Yeah, honestly, I think when you look at like radiation reoccurrence, what you usually do is you get a PET scan, another MRI, and make sure that the reoccurrence is inside the prostate. Most people, if it shows that it's just inside the prostate, should get another biopsy to understand how much of it is and where it's all positive. But yeah, I think it is an excellent option. It's probably the lesser of the evil of the options. Years ago, cryotherapy was probably the most studied one, but I think the side effects for that are significant. Um, Pretty much nobody can get erections afterwards because you got to freeze hard all the way to the nerves. But also then when you go from radiation to then freezing it, the tissue inside the prostate, really gets devoid of its blood flow. So I think this is one of the probably most favorable options. And honestly, that's why it's probably easier for insurance coverage too. We don't really have many issues with that as far as PSA proven prostate cancer reoccurrence and localized prostate cancer. Yes.
Thank you, Dr. McCarthy. Another one that came in. So I know you talked about a catheter, but will I need to be on pain medication afterward, and if so, for how long?
Yeah, that's a good question. So no, usually we don't give any narcotics or pain medication, which is good. Catheters are 5 to 7 days. I always tell people, catheter's annoying. It's not like painful. After a while, you kind of get tired of it, But at the end of the day, when it just goes in there and it just drains, it's more of a little burn. And every now and then, people can have some bladder spasms. So sometimes they'll give a medication if they do, especially if the tumor spot is closer to the bladder, and so that's where the energy was placed. So something for bladder medications and an antibiotic, but no, you shouldn't need any narcotics or pain meds.
Awesome. Thank you, Dr. McCarthy. Another one that came in, so can you talk a little bit about biopsies and frequency after the procedure?
Yeah, so I always tell people when I'm looking for a different answer than I have, I'm doing that. I see a lot of people that came from, say, back in the day, and I had 5 biopsies, and I never had an MRI, and my PSA is all over the map. I get an MRI, and I say, you don't need another biopsy. So everything that I do has some reason behind it, where the information I have and the information that I had, I think, are different. If I'm going to do another biopsy, like there are institutions that are collecting data that are just going to biopsy because they're part of writing a paper. Not me. I want to know when I think I need to find something different. If your PSA is cooperative and you're at some point when we get the MRI, all looks good, I'm not going to automatically biopsy you. There are people who will, but then I look at everything collectively too. how old is the patient? Is this a 52-year-old guy or is this an 82-year-old guy where I really don't want to biopsy the 82-year-old guy again. I'm more worried if the 52-year-old guy reoccurs versus this guy, right? But I would do it when I'm really suspicious for reoccurrence, not just to automatically do it on a protocol.
Thanks so much for answering that, Dr. McCarthy. So I think that actually wraps the questions we received tonight. So I just wanted to thank you on behalf of all of us for taking the time to share your insight and your expertise with us. Again, anybody who's still on, if you would like to make an appointment, please save the phone number that you see there on the screen. And then, Dr. McCarthy, before we close out, is there anything else you wanted to add?
Yeah, I always say this is when you're seeking answers, everyone's really busy. I always feel like in the situations where when I'm a patient, you're always, you don't want to, keep the guy too long, but we're here for you, right? So ask the questions. Who cares if you accidentally offend me? It's about you. It's about the patient. If you have a question and you're afraid to ask it, and then you go home and then you're thinking about and worrying about it and trying to find the answer on the internet or your friend, then our relationship isn't the relationship where we should be able to say, no, Dr. McCarthy or Dr. Rock or whatever you want to call me. Here's a question. It's been worrying me. Get in here. If we didn't answer that, or I didn't fully understand it, or it went over my head, and then I went home and I started reading more. Come back. Let's talk about it. A relationship is where we're able to figure things out together. I never tell people what to do. What I will do is help guide you in the paradigm of saying that treatment probably is not going to have success because it's not necessarily the right treatment for that particular cancer. And here's why. And you also have the right to continue to make that decision. But my guy is to try to say, okay, well, that might not be the right thing, but if you're okay with understanding the risks, the benefits of that, that's fine. And then we together have a good relationship and go through this process together, not just before the treatment, not just during the treatment, but afterwards. What does this mean afterwards when the doctor did surgery on me or did something and I never saw him again? No, I want that relationship where you're proud to come in here and have a relationship with us and get treated. And at some point, we're no longer talking about prostate cancer because we've already done that and it's in the rear view mirror. So that's always my statement is find people that you have a good relationship with and you trust.
Thank you, Dr. McCarthy, and thanks everybody for joining tonight. I hope everybody has a good evening.
Thank you.
Thank you.